Hello, and thank you for joining my presentation. I'm going to be giving on short gut syndrome. So objectives for the presentation today, we're going to review short bowel syndrome causes and prevalence of the condition. There are three types of resection surgery, so we're going to briefly touch on those, go over signs and symptoms. There are three phases of short bowel syndrome and the management of each phase. And then we're going to highlight some of the biggest issues that you can see with patients that have short gut and how to combat those. So first, let's go over some small bowel facts. At 10 feet long and 1 inch in diameter, the small bowel houses chyme from the stomach for up to 4 to 6 hours before it enters the colon, where stool formation occurs. Roughly 9 liters of fluid pass through the small bowel every day, including oral fluids, saliva, gastric, biliary, and pancreatic secretions. 7 of those liters are absorbed in the small bowel and 2 liters are absorbed in the colon. As far as nutrients goes, 90% are absorbed in the first 100 centimeters of the jejunum. B12 and bile salts are absorbed in the last 100 centimeters of the ileum. Magnesium is absorbed in the terminal ileum and proximal colon, and water and sodium are absorbed throughout the entire bowel. Our second brain is known as the enteric nervous system, and this innervates our small bowel and communicates with our gut microbiome, and this is what's responsible for our gut-brain connection. So what is short bowel syndrome? Well, it's a condition in which the body is unable to absorb enough nutrients from food and fluids because there is not enough small intestine present. In adults, it's defined as less than 180 to 200 centimeters of remaining small bowel, and this ends up warranting nutritional support and fluid supplementation for these patients. In Medicare patients, it's actually defined as less than 150 centimeters of small bowel remaining. Now, your normal bowel length is anywhere from 275 to 850 centimeters. Short bowel syndrome occurs when portions of the small bowel have been surgically removed or from congenital intestinal diseases like Crohn's disease, cancer, traumatic injuries, bariatric surgeries, hernia repairs, mesenteric ischemia, post-surgical adhesions, infections, anything related to those conditions. How prevalent is this condition? Well, it's very rare. It only affects about 3 in 1 million people each year. But it's definitely more common in patients that have surgeries, like I explained earlier. So here are the 3 resection surgeries that you can have. So a jejuno-ileal anastomosis, which is where part of the ileum is maintained at the ileocecal valve and gets connected to the rest of the colon. This is actually the one that provides the best prognosis and can help patients avoid parenteral nutrition IV therapy. The next one is the jejuno-colic anastomosis, resection of the entire ileum and the ileocecal valve, connecting part of the small bowel in the middle of the colon. This is the most common anatomy in those with short gut syndrome. And then the last one is a jejunostomy. This has probably the most resection done because the colon is also either completely removed or still present, but just not connected. So these patients definitely require an ostomy bag. So in order for the dietitian to provide the best customized care for a short bowel patient, it's imperative that we receive adequately detailed operation reports. And these need to include the length and location of the bowel removed. We also need to know past medical and surgical history. It'd be good for us to have a baseline 24-hour stool or ostomy output, and whether the output is osmotic or secretory. So how would we assess for this would be, we need to admit a patient, place them on NPO status for 24 hours. And if their stool output drops to 0, then that's osmotic stool, meaning their stool is due to malabsorption of nutrients. Whereas if it's secretory stool and they're having bowel movements, even when they're on NPO, then they're losing electrolytes regardless of food intake or malabsorption. And lastly, a to 72 hour quantitative fecal fat collection will tell us how much fat is being lost in the stool. And this can help assess malnutrition as well. So generally we put patients on a 100-gram fat diet, either orally or enterally, and we assess how much of that fat is in the stool after 48 to 72 hours. Signs and symptoms of short gut syndrome. There are a lot. Mainly we're concerned about dehydration, malnutrition due to malabsorption, medication malabsorption. Patients can form kidney stones and have kidney issues. And this can eventually lead to metabolic bone disease, amongst other things. Diarrhea is another big one, with foul smelling stool or steatorrhea. So let's get into the 3 phases of short bowel syndrome. So there's an acute, adaptation, and maintenance phase, and each of these have different management strategies. So the acute phase begins immediately following the resection surgery or any sort of insult to the bowel. This can last 3 to 4 weeks. And the sheer volume of stomach acid secretions entering the upper gut due to this resection surgery can deactivate and destabilize pancreatic enzymes and bile salts, also impairing micelle formulation. There's a loss of absorptive area and feedback mechanisms that are crucial for regulating food entering the gut. They also regulate intestinal transit time and pancreatic biliary secretions. So short bowel resection surgery can complicate other ongoing medical conditions like digestive disorders, or bacterial overgrowth issues like SIBO. So how do we manage this phase? Well, managing the acute phase starts with managing hydration first and foremost. These patients are at extreme risk of dehydration, which can ultimately lead to kidney failure, acid-base imbalances, and electrolyte abnormalities. So the first thing is to address total intakes and outputs. So you'll see here that we definitely need patients to be putting out under 1,200 mLs of urine. And if they're putting out more than 1,500 mLs of urine, then that can form kidney stones. Stool output of greater than 1,500 to 2,000 mLs can be an issue for dehydration. And here are some common causes for why someone might have a higher stool output. They could have a C. diff infection. They could have been started on new medications, could have been DC'd, important gut slowing medications, drinking too much fluids or poor fluid choices. They could have rapid weight loss, dark urine, which indicates a decline in kidney function, hypotension. They could have previous admissions for dehydration or in the ER for some reason. So all of these could be issues for why they're having a higher stool output that we need to make sure we manage. So the second phase is the adaptation phase, which begins 2 to 4 days after the resection surgery. And this can last up to 1 to 2 years. So this phase involves the structural and functional changes in the small and large bowel that are essential to maximizing absorption. The ileum is actually the most adaptable portion of the small bowel. It increases its villi length, surface area, and diameter. And the colon also works to increase its enterocytes, absorption of fluid and carbohydrates, as well as to slow motility of bowel movements. So management of this phase, first thing we want to do with these patients is maximize their remaining bowel adaptation and absorptive capacity. Now, diet does come into play here, but first we want to get these patients comfortable quickly. So there are some medications we can use to accomplish this. Recall that with a bowel resection or in short bowel syndrome, gastric secretions increase, which means a much more acidic environment in the entire GI tract. So we need to manage this altered pH. So first, high dose acid suppression in the form of hydrogen blockers or proton pump inhibitors can be used. These can be helpful if stool volume is greater than 2 liters with a secretory pattern to the stool output, meaning that stool output persists even when a patient is on NPO. These medications can help slow transit time in the gut and improve absorptive capacity by giving the bowel more interface time with nutrients. Second one is octreotide, which acts to decrease secretions and motility in the gut. The goal dose is usually 200 to 300 milligrams across 3 doses for the day. However, this is rarely needed to manage a high output. Lastly, bicarbonate, which you would think would help reduce pH, is not generally used to manage hypersecretory acid production. The previous 2 mentioned medications are more commonly used. Now, when it comes to bowel adaptation, growth hormone has been shown to improve bowel surface area. However, studies demonstrate only a small benefit, which was short-lived after the conclusion of the studies, and this therapy is actually very cost prohibitive. Glutamine has also been studied in combination with growth hormone with minimal and relatively short-lived benefits as well. It's thought to help with adaptation and mucosal production, and it's generally safe to use, so it's something that you could definitely see could work with patients. Next management tool will be to minimize malabsorption, which goes hand in hand with increasing the absorptive capacity of the gut that we reviewed on the previous slide. But here we're going to focus on bile salt deficiency, which can occur with long ileal resections. Bile acid is reabsorbed from the ileum via the hepatic vein, where it's taken to the liver and repurposed for future use. So without sufficient ileum, unabsorbed bile acid enters the colon, and patients can suffer from fat malabsorption and steatorrhea, which can also result in poor fluid absorption and accelerated motility. So dietitians may think to use bile sequestrants, which work by blocking bile acid from being absorbed into the blood, but this can contribute to fat malabsorption in short gut patients. So be cautious when using bile salt sequestrants. So next, we need to avoid, minimize, or eliminate the need for parenteral nutrition and IV fluids, which means patients still need to be mindful of their fluid intake and the types of fluids they're consuming. So that means less hypertonic fluids, which are fluids that pull water into the small bowel, and they end up increasing stool volume. So this would be fruit juices and drinks, sodas, sweet and liquid nutritional supplements like Ensure or Boost, ice cream or sherbet. Now, on the other hand, hypotonic fluids are fluids that pull sodium into the small bowel in order to increase the osmolarity of that fluid. And along with the sodium, water gets pulled into the small bowel as well, increasing the stool volume. However, these fluids are generally easier for the gut to tolerate and would include water, tea, coffee, alcohol, diet drinks, and they're less problematic than hypertonic fluids. Teduglide is a GLP-2 analog, which is a locally active hormone secreted in the distal ileum and colon. This compound promotes cell growth and inhibits enterocyte cell death. It also helps decrease dependency on IV nutrition therapy. However, this is an expensive medication, so patients need to be parenteral nutrition dependent and have failed other medications and therapies before this can be considered. Finally, the last piece to management in the adaptive phase of short bowel syndrome is to slow intestinal motility. This will help increase nutrient contact time and absorption, as well as improve urine output and decrease stool output. Bowel slowing medications inhibit peristalsis through peripheral opioid receptors in the bowel. Atropine can be used, but it's rare because it has a higher risk of central opioid and anticholinergic side effects. Opioids are another class of drugs that can help slow bowel motility. However, these should only be used when other methods don't work, because these medications are challenging and problematic given the opioid crisis and high rates of addiction. However, if you are going to use opiates to slow bowel transit time, typically codeine is dosed 15 and 30 milligrams in crushed tablets. So the last phase is the maintenance phase. This is actually a permanent point where the bowel reaches its maximum absorptive capacity. It's going to be crucial to manage acute flare-ups with medications and dietary interventions, and monitor fluid and oral intake and outputs through urine and stool. For lifelong optimal living, patients should establish relationships with various medical professionals to work with them as a team. These would include a primary care physician, a gastroenterologist, surgical team, and their dietitian. So we've reached the dietary intervention portion of the management for this condition. Now, these nutrition protocols can be implemented in the adaptive phase as well, but it's more crucial for patients to adopt these for lifelong management of their short gut syndrome. So general tips, 6 small meals a day with snacks as well included in those. Definitely always keep a dietary record to bring to your dietitian. Protein, always want to make sure it's a high bioavailable protein option at each meal and snack. Carbohydrates, we should be generous with those because technically they can be broken down a lot easier than either proteins or fat. Avoid sugar, alcohols in all medications and sugar-free foods. No Ensure or Boost because that's going to be a hyperosmolar fluid. Fat, we should limit fat just because of potential bile salt malabsorption. So we don't want to also malabsorb fat. So limit that to 30% of your dietary intake in patients. May need to limit in those without a colon, as we said about the bile salts. Fiber, encourage some fiber, but fiber is also going to be hard on the gut. So maybe try soluble fiber first. And always encourage food sources versus supplement sources. Let's not be afraid to give our patients salt. So increase salt intake in those with angiogeneostomy and ileostomies. But keep the salt intake typical for those that have a colon. Fluids, oral rehydration solutions are helpful for these patients, especially to keep them off IV medications. So they need to be sipping these throughout the day. Fluids do need to be limited, and we're going to base that on urine output. So they should be having around 1,200 mLs of urine output. Vitamins and minerals have limited evidence for dosing, but if you end up using these for your patients, then you must consider the osmotic drag from all the pills and the fluids needed to consume them. It'll be important to prioritize chewable, crushed, or liquid forms for vitamins and minerals. Converting daily doses or 2 times a day doses to half or just 1 tablet per day. Patients on parenteral nutrition do not need monthly injections of B12 unless the dose is under 3 times a week. Short gut patients need higher doses of vitamin D, so this should be taken daily, sometimes twice a day. We need to avoid the 50,000 IUs weekly, because if a patient decides to go outside and eat something out somewhere and they end up taking their 50,000 IUs, that we could risk too high doses in that day. But get patients out in the sun and expose them to UV light, so that way they can get natural doses of vitamin D along with their 3 times a week supplementation. Calcium should be ingested through the diet or supplemented if needed, and less than 500 milligrams 2 or 3 times a day. So the biggest issues, first is going to be pill burden. So patients just taking too many medications and supplements, that's going to be hard on the gut. And then the fluid amount that needs to increase with taking medication. So that's something that we need to make sure we're keeping track of with our patients and counting out the pills and seeing what we can get rid of and what is necessary. Improper dosing. So no medication, supplements, or over the counter should be as needed. Everything should be scheduled. Patients taking nutrition support supplements like Boost or Ensure. Remember, these have a hypertonic solution to them, and they can increase stool volume, which we are trying to limit. And then lastly, I talked about fluid control ad nauseum in this presentation, but it truly is something that is overlooked with these patients. Patients need to be making 1,200 mLs of urine output, and this will dictate whether a patient needs more or less fluid intake. If they can't make this, then they aren't well hydrated, and that can lead to kidney issues, which isn't something these patients want to be dealing with on top of their condition. So in conclusion, we need to work collaboratively with a team of medical professionals to establish optimal quality of life. We need to monitor oral intake and stool output and fluid intake and output. We need to manage acute flare-ups with medication and dietary interventions and make sure that we can provide the best quality of life for these patients that have short gut syndrome. Thank you.